Thank you so much. So thank you for having me and inviting me. It's an amazing conference. I haven't been to one like this where the families or the patients are right next door to all the scientists and doctors. So just feel very lucky to be a part of it. So I'm going to talk about autonomic dysfunction and autonomic disorders. Start by explaining, what that is. For many people know and some don't, and why it's relevant to smooth muscle disorders. And then I'll talk about what I do as part of the natural history study that Dr. Mussolino connected me to, and then some work we're hoping to do in the future. Hopefully we'll have plenty of time for questions because I think we're ahead of schedule. So no disclosures relevant to this talk at all. So I gave you an outline briefly, but what I'm hoping to talk about is what is the autonomic nervous system and how is smooth muscle involved with a particular part of it, the sympathetic nervous system, which some people may have heard of. That's the fight or flight. Whenever you have a fight or flight response, that's engaging the sympathetic nervous system. We think that autonomic dysfunction in general is very common in MSMDS, and I'll talk about that. And then we'll talk about the next steps and kind of some scientific work trying to figure out more about how smooth muscles are involved in autonomic disorders. All right, so autonomic means acting or occurring involuntarily, like autonomous. So the autonomic nervous system refers to the parts of the brain and the nerves that control automatic things, okay? So if it's in your conscious awareness, cognition is not part of the autonomic nervous system. When you want to move voluntarily, you can control your muscles. So that's not the autonomic nervous system. It really refers to, if you say you want to exercise, your heart has to pump harder, and your brain and your nerves tell the heart to pump harder. Or when you're exercising, you have to direct blood flow to muscles. And so the nerves are responsible for directing blood to the muscles. So that's what we mean by the autonomic nervous system. When you have to urinate, your bladder contracts, and that's not under your voluntary control. But it's still directed by nerves. So the autonomic nervous system is the part of the brain and nerves that deal with visceral organs, things on the inside, and homeostasis, so keeping us healthy, reacting to environmental stimuli. So there's different ways we think about it and classify it, and you certainly don't need to remember all this, but neurologists think of like the central parts, that means the brain, spinal cord, or the peripheral parts, the nerves. We think of it in terms of, what is the function? So there's different components of the autonomic nervous system involved with blood pressure regulation, for example, or regulation of glucose in the body. We sometimes think about it in terms of the chemical, like the signals that are being used. Different drugs, for example, affect different parts of the autonomic nervous system depending on what chemical is being used. And we think of it in terms of afferent, where signals come from the environment towards the brain, and efferent, where they come from the brain towards the environment. I'll talk a little bit more about that. So the main thing that's important, we think, or probably the most important thing, is blood pressure control. When someone stands up, for example, the blood doesn't all fall to your feet because your body's able to regulate blood flow to the brain. And in MSMDS, they can be prone to drops in blood pressure during anesthesia, for example, and that's one example of how the autonomic nervous system we think is important in this condition. So, is there a laser beamer? There we go. Okay, so the sympathetic nervous system, which is involved, in your fight or flight response, one of its main, the most important functions is control of blood pressure. And one of the ways it does that is through controlling what's called vascular tone. So you can think we have arteries and veins all over the body. You can control how big and small the tubes are. And the way that's done is through smooth muscle contraction, in large part. So, for example, when you exercise, the blood to the blood vessels, arteries to the muscles dilate. So if you think you have a certain amount of blood, if the tubes are getting bigger, the blood pressure can drop. So to respond, you have to, increase heart rate and increase and take blood from somewhere else, like from the belly, for example. If you're going to exercise, you don't need to digest at that moment, right? But that proper control of where to shunt blood depends on the ability of the smooth muscles in the veins and arteries to constrict appropriately. So that's kind of one of the ways the autonomic nervous system is most important in this condition, or most relevant. But there's countless other ways with bladder contractility, etc. So this is what I was just talking about. Blood pressure depends on how hard your heart is pumping and how fast, but it also mostly depends on how the caliber of those veins and arteries. Okay, so if you can imagine, if the veins all expand, the pressure inside the vessels goes way down. That can be very dangerous. All right, so as part of the natural history study, children at MGH, or around the world really, or who are coming to MGH, are getting what's called autonomic testing. So that's how I got involved. I had never heard of this condition before. Patty introduced me to it through the natural history study. So I can tell you, some of you probably have been there with family members to the autonomic lab, but for everyone who hasn't, I'll just explain what we do is in the course of autonomic testing. So in autonomic lab, we measure heart rate with an ECG. We measure blood pressure continuously with this finger cuff. So it's not like a blood pressure cuff where it goes on and goes off every, 10 every minute or something. It's continuous blood pressure monitoring. We can measure the amount of sweat that's produced. So that's an autonomic function I didn't mention. You're to stay cool, you need to sweat, for example. And so we can actually measure how much people are sweating given a particular stimulus in a controlled fashion in the autonomic lab, which I can explain more about. Of course, you need equipment to do it and technicians. So that's what we do in the autonomic lab. Here's one example of one of the tests called the tilt table test, which is basically a way to control, you stand up in a controlled way. So patients are put on a board, lying down, and then tilted up. So it's a standard speed and degree and angle, so you can measure people's blood pressure and heart rate response to tilt. Show you some of that data. So what's happening when you stand? As you're upright, gravity pushes blood out of the chest into your belly and your legs. As you remain standing, the pressure in the blood vessels pushes some of the fluid out. So people actually have less intravascular volume with prolonged standing as a result. And so healthy people compensate, and that's why we don't all pass out when we stand up. And there's different ways to compensate. One is by, unconsciously, we kind of shift side to side and our leg muscles constrict and it pushes blood back up. Another way is through what we call neuroendocrine system, so hormones that help your body hold on to salt and water. But the main thing in most people is what's called the baroreflex. So your body has these organs in the great vessels like the carotid artery and the aortic arch, heart, where it senses a drop in blood pressure, sends a signal up to the brain, and then there's a compensation. The nerves then tell the heart to beat faster and tell the blood vessels to constrict to maintain blood pressure. So in normal, healthy people with an intact autonomic nervous system, we're able to react to upright posture and maintain blood pressure. That's called the baroreflex. So this is just a description of what I talked about, where with some anatomy, which I might skip over. Neurologists like this kind of thing for everyone else. We get to sleep. So we can measure blood pressure and heart rate during tilt. Another thing we can measure in the autonomic lab is people's blood pressure and heart rate response to breathing out very hard, what's called a Valsalva maneuver. So when you exhale for about 10 or 15 seconds, is a very stereotypical response that we can measure in the lab. You have to be able to breathe out hard for 15 seconds. So it's not really, it doesn't really work for young children. But we can try. So when you breathe out hard, you increase pressure in your chest. And so blood has a hard time getting back from the belly and the legs because of that increased pressure. So blood pressure starts to drop during a Valsalva maneuver. So let me show you what we're looking at. So blood pressures on this axis and times here. This is during a Valsalva maneuver, the black. So blood pressure starts to drop because of that increased intrathoracic pressure. If you have an intact baroreflex, your body senses that increase and responds by increasing your sympathetic outflow, constricting your blood vessels, increasing your heart rate, and the blood pressure normalizes. This is what it looks like when that's not working, which is the blood pressure just keeps going down without a compensation. And then you release the Valsalva maneuver here, and it takes a long time to get back to normal. So this is about 10 or 15 seconds. It can take, 20 seconds or 30 seconds, depending how bad the problem is. Normal is like less than 4 seconds. So this is the standard way to assess the baroreflex, which is an important autonomic function that we do in the during clinical testing. We can also look at the heart rate changes. As your blood pressure is dropping, you have this response, heart rate increases to compensate. And then afterwards, when the blood pressure, you have this overshoot because the sympathetic nervous system is revved up and the blood pressure is restored in the chest after you relax the Valsalva maneuver. The heart rate goes way down, and so you can measure the difference, and that's another way to assess whether the autonomic nerves are working like they should. Another thing we measure in the lab is what's called quantitative supramodal axonal reflex testing, which is a measure of sweat. So it's kind of a long acronym, but kind of an interesting test that was developed about 40 years ago at the Mayo Clinic, where we have these capsules, and you can use an electrical charge to push a chemical called acetylcholine into the skin. And when it contacts the nerves send a signal to the sweat glands. If that system's all working, it produces sweat, and we can measure the change in humidity. It's like the tube is attached to this desiccant, a very dry chamber, so you can detect a very minute change in humidity and quantify the amount of sweat produced. So this is important because it's one of the few tests we have to look at whether these teeny nerves in the skin are working or not. They're hard to assess otherwise. In this case, we're interested in the sweat production. We think the nerves are normal, but there's actually smooth muscle cells in the sweat gland that are involved with pushing the sweat out. So it's kind of a way to measure smooth muscle function through sweating. And that's illustrated here. There's little myoepithelial cells here in the sweat gland. All right, so far we started this as part of the natural history study last year, beginning of last year. So I think we just had our 11th, but there were 10 children who came in last year. Here's a sort of description of the age of diagnosis, which you all know this already. And I think there's a longer talk later on the natural history study. Many patients do have problems that might be related to dysfunction of the autonomic nervous system. Things some of the families and patients will know better than me, but things like fatigue, trouble exercising, which might suggest trouble mounting a heart rate response appropriately or maintaining blood pressure. Either passing out from not enough blood to the brain or feeling like they're gonna pass out. Those are symptoms of autonomic nervous system dysfunction. And then I'll get into some of the data in a different way a bit later. So we measured people's heart rate during the tilt and blood pressure and sweat volume. And just to back up a bit, one of the ideas here is that as therapies get into the clinic, how do you know if they're working? So you have to have some way to track progression of the condition in a formal way. So that's what the natural history study is about. And this is part of that. How can we tell as the condition, I mean, there's a lot of ways to tell the condition progresses, but in a formal way, so we can test treatments. This also helps, with figuring out, we think autonomic dysfunction could contribute to strokes, for example. So, how are we going to figure out how to better treat that? That's the rationale here. So one of my colleagues named Erica Williams has been helping look at the data and doing some other tests I'll tell you about. I'm presenting partially on behalf of her today. So she helped graph. These are the 8 patients we've had so far. And what you can see, so this is during a tilt table test. So during the tilt table, people lie flat, we measure blood pressure and heart rate, and then they're tilted up to 70 degrees, and blood pressure and heart rate are measured, continuously, but graphed here, I think we have like 5 spots we've graphed. And during the tilt, the younger children seem to have less of a heart rate increment, so their heart rate might go up by 10 or 20 with tilt, while the older children, it goes way up. So there seems to be a progression. It's not a big number of patients, and we haven't repeated it year after year yet. This is just the first year. But it seems that as they age, at least in this data set, there seems to be a change where heart rate goes up more with tilt. And similarly, some of the patients' blood pressure drops significantly, which is not normal. All of us, when we stand up, are able to maintain blood pressure. In the children who've gone through so far, the older children in particular seem to have a bigger drop in blood pressure. So there does seem to be some difference. We need to study it formally. It's pretty preliminary, but as people get older, the blood pressure seems to drop more with tilt. Sweating, there is overall, I think, decreased sweating compared to normal, but the sweating normal data is not that well established in this age group. So we need to do some more digging to figure out, one, whether this changes over time, and two, whether this suggests smooth muscle dysfunction. It's kind of what we're doing in process now. So to try to figure out, there's a sort of critical question about what's happening here. Is it all the smooth muscle, or are the nerves also affected? That's an important question, right? If we were to be able to fix the smooth muscles, would it normalize? Or is there some other problem going on too? Because there's evidence that during development, the nerves are listening to the smooth muscles. So if the smooth muscles are dysfunctional, perhaps the sympathetic nerves won't grow and form an appropriate connection with the smooth muscle. So it's one possibility. Even if we're to fix the smooth muscle, there's a question about whether the nerves have developed appropriately or not. So to help look at that question, in the mice model, Dr. Williams, who's kind of an expert in the sympathetic nervous system and autonomic ganglion, has been looking at comparing normal mice with the ACTA2 mutation and staining for different markers of sympathetic nervous system integrity. And so far, very preliminarily, she seems like the mice nerves are developing appropriately. So the nerves are having the normal expression of different proteins associated with normal sympathetic nervous system function. The sympathetic nervous system is not working like it should, but it's probably, at least based on this preliminary data, restricted to the smooth muscle dysfunction, not the sympathetic nerves, which are talking to the smooth muscle. But again, very preliminary. Unfortunately, there's a lot of different functions of the autonomic nervous system we can't test in the clinical lab, things like urinary function, the gut moving, the eye pupillary function. So that's one limitation, is we do what we can in the clinical lab, but we can't test all aspects of the autonomic nervous system. All right, so I am gonna stop, but I'm happy to talk for as long as possible with questions, as much time as we have. So I think the conclusion is that we have found, children with MSMDS seem to have a number of autonomic symptoms, manifestations. It seems that smooth muscle, which is actually something in our field in autonomic neurology we don't think of very much. We really focus on the nerves. So I think this is important for the field of autonomic neurology to kind of conceptualize the idea that smooth muscle disorders can contribute to autonomic dysfunction. That's not something we've thought about very much in our field. So I think that's an important way to reframe our thinking. And then we need to do some more investigations about how we can help with autonomic dysfunction, how that dysfunction is contributing to poor quality of life, fainting or lack of exercise, and what medicines might help address that. So these are some ideas we have for the future. Kind of doing some more studies on the animals to understand what's going on with the nerves and the muscles, and then tracking progression over time, as each year, as we do clinical autonomic testing on children in the natural history cohort, we'll be able to better identify what happens, how does autonomic dysfunction contribute to strokes and other problems that arise. So first, I want to thank the patients and families who came for the test. I know it takes a tremendous amount of time and dedication, so thank you. Of course, the organizer of the conference, Patty, for inviting me, and for her collaboration. Erica Williams, who did a lot of this work, and then all the other folks involved with the natural history study and the autonomic testing. Thank you, and we'll stop here, and I'm happy to answer questions.
Thank you so much, Nate, for taking us on this. The autonomic function has been raised by the community like multiple times. Like, what do we know? What do we do with it? And one of the challenges is the age, no? So you can only do the formal testing on like 5 already is a stretch in the lab. I know that, and we only can do it kind of like 6, 7 years and above. In terms of the symptoms, the autonomic system also innervates the gut. We know a lot about gut symptoms in these patients. There are some scales. Do you have headaches? Could be also part of the autonomic dysfunction. Do you have any sense of how we could capture the symptomatology of this possible dysfunction in younger kids? And also, like, what will be in your kind of like right now the best proposed approach to kind of try to improve the things that we can to kind of minimize the symptoms from the autonomic perspective?
Yeah. So a couple good questions. It's the problem in the autonomic lab. I mean, we require people to do deep breathing. If anyone has, children have a hard time with that. This sweat testing causes some kind of burning or tingling, so not too painful, but can bother children. So other ideas first for either quantifying or testing the younger children. I mean, there are some other tests you can do that don't involve the same methods. They're not as standardized, which makes it harder to judge the results, but we can monitor blood pressure, for example, and stress people out, which we try not to do to little children. But in kids, if you have them do math in their head, older kids or something, people's blood pressure goes up, and so you can actually measure that or put their hand in very cold water. So there's different ways to measure blood pressure responses, even in younger children. In terms of the symptoms, I mean, that relies on self-report. So it's, you can ask them how they're doing. There's a number of scales, but in adults, the self-reported autonomic symptoms don't correlate well with autonomic dysfunction, which So, you know, the symptoms are probably the most important thing in terms of quality of life, but when we're looking at sort of objective autonomic function, if you ask people about if they're lightheaded or how if their sweating is not normal, they're constipated, there's different autonomic symptoms that really don't correlate with the autonomic testing. So that's a problem, either with the scales or with the tests. But it's hard to get people's accurate symptom assessments and hard to know what we're measuring when we're asking them. Second part of the question.
Measurements that you say, with all the limitations, what can be done to minimize autonomic dysfunction?
Yeah, the symptom, right, treatment.
Yeah,
So,
symptomatic treatment.
yeah. You know, as an autonomic doctor, we are sort of uniquely, we see patients whose problem is low blood pressure. They pass out or they can't exercise because they can't increase their heart rate. So yeah. So I can tell you in adults, a lot of what I do is sort of argue with the cardiologists and nephrologists. Because it's very important to keep blood pressure low, especially when you're prone to, you know, aortic complications, or there's so many complications of high blood pressure, stroke, kidney disease, heart disease, aortic dissections. But for the most part, in people who are with autonomic dysfunction, the low blood pressure is much more bothersome. And there's not a lot of data for this, unfortunately. So that's one of our tasks, is to formalize this, you know, opinion. But you know, you can't live when you can't. It's not a good quality of life when you can't exercise, pass out, or almost pass out for the heart. So we tend to favor higher blood pressures. And you know, I think it's an open question about what the optimal target is that we need to try to you know, target or answer that question. But I think one thing would be sort of, you know, being more cognizant of whether the low blood pressures are contributing to symptomatology and potentially being less aggressive. But you know, we don't know. I'm talking about a stroke doctor. Increasing blood pressure is not, you know, looked upon well, but I think that's a possibility that we're over treating. We have to try to assess that somehow. I can say in adults with autonomic dysfunction, we use ambulatory blood pressure monitoring.
Yeah.
Which we should consider. So it's kind of annoying though. Kids have to tolerate it. You can wear it at home and it goes off on its own every half hour, or you could set it, or every 2 hours. And then you get a sense of the blood pressure fluctuations through the day. And we could look at whether when people are symptomatic, is it correlated with low blood pressure or what? So that's one thought.
Thank you.
Do you have a less invasive way to do that besides a blood pressure cuff to measure blood pressure?
There's things on the market, but they're not validated yet. So there's a new device we're working with, you know, where they're measuring blood flow at the ear, you know, which is the external carotid, but it's a proxy for perhaps the same things happening in the brain. So that's a wearable, pretty comfortable device, but it's, you know, not validated yet. And there's people that chest devices. There's a lot of different things people are trying for continuous blood pressure monitoring, but nothing that's really ready for prime time. Other questions about autonomic dysfunction or anything else? Yes.
So with the neurons, I know I saw the results for preliminary with the neurons being intact. But if it's more downstream, if it's obviously if the vascular response is blunted, definitely, and we know with our mice studies that there is neurovascular defects. So I'm just trying to see this in terms of like whether it would be like a classical neuropathy. So how would you differentiate this in a clinical setting? How would you differentiate something that's pre-ganglionic versus like end organ failure, and you know, how can this be correlated with MSMDS? What can we classify this as?
Yeah, that's a great question. So the question is sort of clinically, how do you know if it's the nerve or the muscle or what is going wrong, basically? Is that right? Yeah. So with our formal autonomic testing, we can't tell the difference. We're looking at the end result. The problem could be anywhere. That's why partially I think it's such a, in general, putting MSMDS aside, we have not really considered the idea that some of these abnormalities could be muscle before in my field very much. So I think it's a very important revelation in some ways that needs to be followed up. There are some ways to tell it apart clinically. You can measure, norepinephrine spillover as a measure of sympathetic noradrenergic integrity. You can, the problem is for most of the gene expression stuff, you need neuronuclei. So that you can't really do that in people very easily. But there's neurochemical ways. There's some imaging techniques, but again, you have to sort of sit still. You can measure noradrenergic integrity with fluorodopamine scanning, fluorodopa scanning, if you're looking at the brain, but fluorodopamine in the periphery, or other techniques like that, MIBG scanning, looking at
There's no way to look at innervation density or that's.
Well, we do skin biopsies, but you get into invasive testing is the problem. So in a natural history study, we can't do that. But yeah, with a skin punch biopsy, which is pretty minimally invasive, everyone has, a lot of people gets that at the dermatologist or something. It's just like a little biopsy. You can do a lot of staining and look at the nerves and the muscles.
And what about conduction velocity, like classic energy? Would that be any?
That doesn't help. No, these are very small diameter nerves that are generally unmyelinated, but the nerve conductions in EMG don't work. So there's other, more experimental techniques to look at small diameter nerve function, autonomic function, but it's mostly the testing we talked about that are really well validated. Good question.
You said that in general, older patients are more affected by the TIL test. What causes that difference? And is that difference similar in non-MSMDS patients?
Good question. So it's not similar in non-MSMDS patients. So normally people actually, when you're children, pediatric age people in general, have higher heart rate than adults with TIL, but not this high. So this is abnormally, the heart rate augmentation is not normal. That's abnormal, the degree that we're seeing. I don't think we understand what's happening yet with what changes over time from with age. I think this study that some of these children will undergo repeat testing will be able to tell better what's going on. But yeah, I think this is a new finding. Some of you might have known about it already, but the general community didn't.
And I would say we threw Nate to the, hey, could you present? And we barely got the data out. A lot of the questions that you guys are asking, it might be on whether or not these patients had aortic replacements or not. Like, you change the contractility or the elasticity of the vessel when you put a graft. So basically it's no longer like elastic, or there might be things from that aspect. We don't know it until we analyze the entire data set of the natural history. For those of you that have been participating, you've seen how kind of extensive the assessments are. We are doing 24-hour blood pressure annually. Kids are putting up with it. So, and we'll learn a lot from these analysis, but every single aspect of this, I don't know if you saw, he had to engage another colleague that uses computational stuff to get the data out of it and try to analyze it and correlate it with things and stuff. There's a lot of work to be done. So if anybody has come across anyone that also has been doing either the patient-reported outcome surveys, or we really need help. It's a multi-system disease. I have one expertise, maybe a couple more from critical care, but we really need a community to think about such a complex disease. And I think you heard how much it helps. You're not bothering someone when you ask them to look into your disease. It might open a full entire new field in their expertise, because, well, what about smooth muscle? I keep getting the results before Nate came of, oh, this is small fiber neuropathy. I was like, I don't think so. I know one thing, the smooth muscle doesn't work. The nerves everywhere else seem to be working. So I have less suspicion on a neuropathy than smooth muscle. The answer is not yet out there. So we have to do research. We have a mouse to ask some of these questions. Erica Williams is also going to look into the mouse to try to answer more specific stuff, but always try to help us here because it's complex and there's a lot of work to be done.
Oh, we have a Zoom question, hold on.
Do we know why older children are seeing bigger drop in pressure and take longer to stabilize?
Yeah, it's a great question. We don't know yet. We have some thoughts, but we really don't know.
Could it be correlated with disease progression?
It definitely could. That's one possibility. Yeah, there's also, changes. Some of them have undergone surgery. Some people are on, medications, although doesn't seem to be related. So we really don't know yet.
TBD.
Yeah, TBD. Important question though.
Any other questions? All right, thank you very much.
Thank you.